Good evening, everyone. So today, along with us, we have Dr. Sandeep, who was first MD from JIPMER and currently doing senior residency in who are DNB candidates, appearing to be Viva on 30 and 31st of this month, and will help us to face the exam and also the fear of exam. Over to you, sir.
Yeah, hello.
Hello, sir.
Yeah, am I audible?
Yes, sir. You are now audible to us.
Yeah. Okay, we shall begin. Myself, Dr. Sibi. I'm 2015 MBBS batch passed out. So, I finished my MD recently, only from JIPMER from Pondicherry. So, um, yeah, am I audible now?
Yes, sir. You are audible, sir. Yes, sir. You are audible, sir.
Okay. We will go to that last case, that case number 6 I had told you today. We
Okay,
will
sir.
begin with that, and then we will proceed with the spotters.
Okay. So, sir,
We
we'll
have
give
one long. Yeah.
we'll give first opportunity to the one who have not attended yesterday. First of all, we'll give to opportunity serially to who are new today. So
Okay.
first to Dr. Ujjal Vishas. Are you there? Dr. Ujjal Vishas? If not, we are going moving to MJ Sushil. Hello. Is there any issue related to the audio with anybody? Dr. Mohan Krishna? So coming to the one who were present previously. So I'm coming to Dr. Arya Mahapatra. Dr. Arya Mahapatra, are you there?
Hello.
Dr. Arya. So I'm giving you the first case.
Yeah.
Okay.
Dr. Arya, can you hear me?
Yes, sir, I can hear you.
Okay. So we will proceed with the long case. This is the case which I got for my final examination. The recent exam I got opportunity to attend to in JIPMER. So this was the patient, a 54-year-old male. He's a former patient. He had history of fever for 2 days before coming to the hospital. He had mild myalgia. He later on went on to develop acute onset bilateral lower limb weakness, which was involving bilateral lower limbs, weakness of both proximal and distal lower limb. which had progressed to involve his bilateral upper limbs. So he had weakness of both bilateral lower limbs and bilateral upper limbs, which was acute in onset and rapidly progressive over past 2 days. Along with this, the patient also had complaints of tingling sensation bilateral plantar aspect of the foot. He then went on to develop left-sided facial paralysis in the form of deviation of angle of mouth to the right. Okay,
Okay, sir.
yeah. So with this history, what are the differentials can you provide? So whenever you are presenting a long case, whatever the examiner what order you have to write the case sheet is, first you have to take a detailed history. After proceeding with the detailed history, you have to give a provisional diagnosis based on the history, right? So this is the
Yeah.
history I'm giving to you. What are the differential diagnosis you can tell?
Sir, as from the history, patient is presented with the fever for the 2 days with myalgia
Yeah,
and acute onset symmetrical ascending weakness, first in the lower limb and then in the upper limb, both proximal and distal.
yeah.
So this is an acute onset episode. This may be due to the first of all, it is acute onset. That is, it may be any vascular cause and maybe any inflammatory cause. And in case of any inflammatory cause, it may be infectious or non-infectious. Uh, in case of vascular cause, we can we can take in our differential like vascular in accident like in anterior spinal arteries, posterior spinal artery or anything, or hematomyelia, or in case of inflammatory like infectious inflammatory cause, it may be transverse myelitis or any form of myeloneuropathy. Or if it is non-inflammatory, then we can consider the radiculoneuropathy or polyradiculopathy, maybe inflammatory demyelinating polyradiculopathy, or maybe it may be only myeloneuropathy.
Okay. So based on the history, since they have presented it as acute onset, you have
Yeah.
told it could be a vascular, right? So you're partly correct. But patient is characteristically having ascending quadriparesis, ascending flaccid quadriparesis associated with cranial nerve involvement. So this kind of presentation happens particularly in a disorder. We all are very in southern part of India. It is very common. So that is GBS, which is Guillain-Barré syndrome, acute inflammatory demyelinating polyradiculopathy. So you are correct.
Yes, sir.
So since it's a farmer, another possible differential which we encountered in this kind of vegetations where Pondicherry is situated, snake bite is very common here. So
Yes.
snake bite, so particular snake bite can also produce ascending areflexic quadriparesis. So that is one of the important differential diagnosis you have to consider,
Yes, sir.
particularly cobra and crate. Of course, crate will not produce any bite mark, but cobra is very common. And third differential is hypokalemia. So again, this part of the belt where most of the population are doing farming in tropical climate, these patients are predisposed to a form of endemic CKD. They will all will present with a determined kind of phenotype with hypokalemia and hypomagnesemia, which is also called as Thondai-Mandalam nephropathy in Tamil Nadu. There are many articles regarding that in the NCBI, and in Andhra Pradesh they are calling it as Uddanam nephropathy. In these areas there are people who are farmers who work in tropical climates. So the cause of CKD is not yet known. Some are relating it to dehydration, some are relating it to lead intoxication due to the high concentration of lead in the soil. So these are the possible three differentials which I will consider. Okay. So
Okay, sir.
yeah, we will proceed with the next slide. So These are the possible three differentials I will give. Even if we from this history we are not able to localize whether it is an UMN or LMN pathology.
Yes,
Since
sir.
it is an acute event, even in UMN there won't be much of an spasticity or hyperexcited reflexes. Even plantar will be mute. So the history was not telling us anything, but acute onset air reflexive quadriparesis, which is ascending, these three are the possible differentials. One is number one should be GBS since fever history was there, and bilateral lower limb tingling sensation, after which this followed. And number two will be snake bite, and number three will be hypokalemic paralysis. Right. So we will go to the next slide. So on examination, he was conscious, he was oriented. On presentation, he was afebrile. His vitals were stable, BP pulse, everything was stable. Going to the central nervous system examination, was conscious, he was oriented. KNL examination only showed left-sided facial nerve paralysis. And the power in the lower limbs it was 3 by 5, and in the upper limbs it was 2 by 5. So, important practical aspect is there. So, patient is having bilateral lower limb power of 2 by 5. What is 2 by 5 power? I mean, motor muscle power grading.
So 2 by 5 means means limb is maybe movement in the horizontal direction, nullifying the gravity.
Exactly. He is not able to move the against the gravity. And 3
Yes.
by 5 is
3 by 5 is just against gravity but without
exactly.
resistance.
Exactly. So you keep in your mind regarding the power alone, you keep in your mind. And sensory examination was intact. Of course, he was conscious, put so he was able to answer. And all deep predominant reflexes were absent. Plantar was bilaterally mute, and cerebellum was not tested. So again, there's a catch in this. Since patient is having a motor weakness in bilateral upper limb and lower limb, you cannot check cerebellum routinely. So during examination, with patients having quadriparesis, don't voluntarily go and tell about cerebellum examination, which is non-relevant. You can tell titubation to the least. Otherwise, don't mention this upper limb, finger, nose test, and other tests and heel shin, knee test, and all. You don't mention in examination because it looks silly. So this is the one thing I wanted to tell. And other system examination obviously was normal in this patient, cardiovascular, respiratory, and abdomen examination. So next slide, can we go please? So with this history we have provided and examination also we have provided. So can you tell the differentials now? Yeah,
Uh,
nystagmus for cerebellum we can obviously look. Yeah, nystagmus we can look. So the provisional diagnosis could be
sir,
acute.
professional
Yeah.
GB
Like,
syndrome.
yeah, GBS will be the again. We cannot rule out the other possibilities of snake bite. As snake bite is not in the history, so it is obviously ruled out. And hypokalemia, the blood reports will be available. Hypokalemia also can be easily ruled out. So now we are proceeding with the differential diagnosis of first differential diagnosis of GBS, it is AADP. So okay, now you tell what are the investigations you will do apart from the basic investigations of complete blood count, RT, and
Sir, I will do a CSF study to show the pleocytosis and also do the nerve conduction study of the both upper limb and both lower limb.
okay. Okay. So patient is having symptoms only for the past 2 days. Will you do CSF now or you will do it later? Can you elaborate on it? Will you do CSF study now only? If you do
CSF,
CSF now, what is the characteristic CSF finding of GBS?
CSF finding will be aluminocytological dissociation.
Yeah, so patients will have increased protein with the normal cells, right?
Yes, sir.
So basically, what we have seen many cases in JIPMER, but our consultants never urged us to do LP for GB if we are suspecting GBS because GBS, galvanocytological dissociation, happens at the end of 1 week. And
Yes, sir.
changes in nerve conduction study also happens at the end of 1 week. Unless or until the patient is having ongoing fever has not subsided and weakness is still present, then there is an pressing indication because If cells are more than, Harrison also mentions that if a patient is having lymphocytic pleocytosis along with fever, along with GBS kind of presentation, the possible differential we are looking at is CMV polyradiculopathy. Okay,
Yes.
so if patient is having persistent fever and fever is not subsided and along with that weakness is there, then LP must be done immediately. Otherwise, we can wait for LP. So, nerve conduction, coming to the nerve conduction study, I want to ask the basic thing. How will you differentiate axonal versus demyelinating neuropathy based on NCS?
Sir, I don't have much idea, but
Yeah.
as much as you know that the AF wave we should be that should be based on the pattern of AF wave.
No,
I don't have much
okay.
idea. Like,
So, prolonged F wave latency, they will tell. There are two waves, F wave and H wave. So, basically, the demyelinating disorders, the velocity, that is the conduction velocity, will be reduced. But for axonal disorders, conduction velocity will be normal. But in axonal disorders, what will be reduced is that CMAP, that is the amplitude, compound muscle action potential. The amplitude will be reduced in axonal neuropathy, while conduction velocity will be decreased in demyelinating neuropathy. In demyelinating neuropathy, coming to that, in GBS, there will be prolonged F5 latency along with the increased dispersion. The details of which you can read later. So basically, based on amplitude and conduction velocity, you can differentiate between axonal and demyelinating neuropathy. So these two are the basic investigation steps. Of course, HIV you have to rule out because HIV is associated with CME polyradiculopathy. So you have to go to immunocompromised conditions in this patient. So these are the basic investigations you will do. Coming to the treatment, yeah, what you will treat, what you will treat with.
so treatment can be done by IVIG or plasma exchange.
Okay. Okay, yeah. So IVIG, you have to give zero point 0.4 mg per kg per day for 5 days, and plasma exchange around 250 ml per kg of body weight. You have to remove alternate days. I mean, first day, third day, fifth day, seventh day, and 10th day, you have to do plasma pheresis and remove plasma. Okay, so another important tricky question I have to ask. Oh, well, based on what parameters you decide whether to give IVIG or whether to treat it with plasma pheresis? How will you decide?
Sir, I don't know, sir. This one.
Not duration. So in GBS, I wanted to ask, there are many variants of GBS, and one variant is acute pan dysautonomia. Some patients present only with severe autonomic dysfunction, and of course, many patients present with acute flaccid paralysis along with autonomic dysfunction. Particularly IVIG is very costly. Okay, so it comes in lakhs. But plasmapheresis, so a single dialysis machine along with a filter, which costs around 15,000, and a few FFPs and albumin is enough. So in government setup, we used to initiate treatment with plasmapheresis only. But the problem is after initiating these patients with plasmapheresis, after one or two sessions of plasmapheresis is a dialysis. So whatever form of dialysis we give, the dialysis itself will create a form of hemodynamic instability, and it will further worsen the hemodynamic instability which the patient with GBS is already having. There is autonomic instability. So these kind of patients will go into sudden onset hypertension, pulmonary edema. Suddenly their BP will decrease because of the autonomic disturbance, which they have because of the disorder itself. So in these kind of patients in whom after initiating plasmapheresis, this autonomic disturbance is happened, we used to stop plasmapheresis and start IVIG instead. If patient is affordable, the better drug always is IVIG since plasmapheresis always has side effects, and particularly these patients are more prone to develop pulmonary embolism. Since you will be removing an n number of clotting factors and you will be pushing n number of clotting factors, be it in the form of FFPs in plasmapheresis, these issues are bound to happen. Hence, IVIG is always the better bet if patient is affordable. Otherwise, usually we proceed with plasmapheresis, and if autonomic instability happens on the way, then we will change to IVIG. That is the course of action usually we take. So this is the treatment for GBS. Uh, Coming to the next slide, yeah. Can you tell some 5 variants of GBS?
Variants like uh, acute motor axonal neuropathy, acute motor
Yeah,
sensory axonal neuropathy,
yeah.
Miller-Fisher variants, and these much I don't.
Pharyngocervicobrachial variant, then polyneuritis cranialis, where only tail will be affected without affecting the other parts of the body. So these are all the variants of GBS. So this is enough for GBS. And the Miller-Fisher syndrome, can you tell the triad?
Um, uh, Miller-Fisher syndrome, uh, weakness plus ophthalmoplegia and ataxia.
No, ophthalmoplegia, ataxia, areflexia, right?
Reflex,
So
yeah.
actually, I have also seen one case of Miller-Fisher syndrome. The characteristic feature is the ataxia and Miller-Fisher syndrome. Till date, they have not been very much sure whether it is a sensory ataxia or whether it is a cerebral ataxia. And most of these patients will also have a truncal ataxia with peripheral ataxia. So it is very difficult to ascertain whether it is a peripheral ataxia or a central ataxia like in cerebral one. So that much I wanted to know. And so causes of ascending paralysis we have already told. Can you tell the cause of descending paralysis?
Descending paralysis, peripheral neuropathy,
Hmm.
and and myopathy, proximal myopathy or distal myopathy with
Yeah, yeah.
with including spinal cord involvement myopathy or myeloreticulopathy or myeloneuropathy maybe.
No, actually the descending causes, the common causes include botulism, okay, botulism and tetanus.
Mm.
Botulism or tetanus you should have in mind. And one more question there, if they are asked in my exam, I will ask. So this patient was having acute onset symmetric paralysis, right? So what will
Yes,
you consider if patient is having acute onset asymmetric paralysis, particularly in
if it
India?
is acute onset asymmetric paralysis, then we will think of any cord lesion that may be compressive myelopathy.
Yeah, that is accepted. Another condition is polio. You have to think of.
Polio. Huh?
Yeah. So what are the criteria for AAV to the recipients? You know some name criteria.
Criteria.
Yeah, the criteria are Brighton and yeah, someone else.
Written criteria.
And Asbury, right?
Yes.
Yeah. So these two are the named criteria you can go on to this. They are not that much important since TBS you can diagnose clinically only. And other questions I have asked you, the findings in lumbar puncture, psychological assessment, they have to do at the end of 1 week. And the NCS politics also we have discussed. And what to do if patient is having autonomic fluctuation, I also told. We have to stop plasma paralysis and we have to give IVH.
I
Yeah.
wish.
So I wanted to ask some more things about snake bite. So what are all the big four of? I think I'm torturing you too much, Doctor Arya. Can someone else answer?
No, sir, it's okay.
Yeah. Okay. Yeah. I'm asking what are questions they have asked me. That. So since it was in the differential, I'm asking. So what are all the big four? The big four snakes of India.
Bigfoot snakes are maybe neurotoxic and musculotoxic.
Yeah, right.
Musculotoxics are vipers and neurotoxics are great.
Yeah, neurotoxic and vasculotoxic snakes. So the common snakes include Indian cobra, Russell viper, and the saw-scaled viper, along with common kite. So these four are called as big four Indian snakes. The important thing is all these four are venomous snakes, and
Yes, sir.
the anti-snake venom, that is the ASV, which we will give. Uh, it has these four snakes anti-venoms at the dose of 0.6, 0.6, 0.45, and 0.45 mg. So why I'm asking this is whenever we sit in a year as a medicine residents, And usually, whenever the patient came with without any history, and the patient comes with acute onset coronary paralysis, what they tell is we can even prophylactically start ASV for these patients. So that is what I have been taught here. If you are not
Yes.
able to, because this common crate commonly doesn't leave a bite mark. Patient will be going for sleep with the next day morning. You haven't found. They will find him quadriplegic, and they will send the patient here. And patient will have quadriplegic paralysis, and there will be no muscle tone, nothing. It will be element quadriplegic paralysis. We will be confused whether it is GPS or snake. But in these kind of scenarios, it is better to give what we tell you ASV. So
And
for benefit of doubt, and the maximum dose we can give for neurotoxic snakebite is can inhibitor. It is 20 vials. For hemotoxic snakebite, it is 30 vials of ASV. For neurotoxic snakebite, it is around 20 vials. So that much. This is very very important for you to know, because the snakebite is very very common here. And I have personally seen this Russell Viper particularly is very deadly. That here we have reported some 3 or 4 cases of massive pituitary necrosis where patient went in for diabetic insipidus. That patient has literally around output per day which is said to just collect the urine and just discard that. So that much amount of diuresis will happen, and so much fluid resuscitation and the patient eventually died. That was my first case I saw when I joined PG there. So that was a memorable experience. So it's very very important, particularly Russell's Viper. It's a very very deadly snake, and some of you have come to Pondicherry. How many have come to Pondicherry? Yeah, no, no response. Okay. So we will proceed with the Viva.
Sir, moving to the next question to Dr. Sunam.
Yeah.
Dr. Sunam, are you there?
Yes, yes.
This case is for you.
Yeah.
Okay. Can I start?
Yeah.
Okay, sir. 58-year-old male with a history of hypertension and smoking presents with acute onset retrosternal chest pain, radiating to the epigastrium for 4 hours, associated with nausea, diaphoresis, and dizziness. No history of syncope or prior similar episodes. Examination reveals hypotension with BP of 90/60 and pulse rate of 62 and clear lung fields.
Yeah. What do you make of the
E
ECG?
So ECG is suggestive of inferior wall MI.
Okay. Which is a STEMI or an STEMI only, right? Two,
STEMI,
three
yes,
AVF is
sir.
showing
2-3
AVF.
AVF ST elevation with reciprocal changes in AVL.
Okay. Can you tell which artery is involved?
Sir,
Which is the
RCA,
culprit artery? How is
right,
it?
inferior wall MI usually involves
Yeah.
RCA.
No. Instead of MI, both RC and LCX can be involved. The basic trick is you have to see the 2-3 AVF, whether lead
Mm.
3 is elevated than 2 or 2 is elevated than 3. Here, lead 3 is much more elevated than lead 2.
Mm.
So, this is an RC occlusion. But if lead 2 is more than lead 3, then it becomes an LCX occlusion. And also, you have to comment on the involvement of the right ventricular wall and the posterior wall. Here, right ventricular wall, usually right ventricular wall, we have to see the right sided ECG. Here, right sided ECG is not present. And for posterior wall, you have to see V1, V2, in the anterior leads, V1, V2, V3, any ST depressions are there. Yeah, if any ST depressions are there, then it's a posterior wall involvement. This question is not fitting the ECG. Usually, patients will also have RBMA to develop hypotension, but here only if wall is involved. Actually, the ECG and the question are not fitting each other. But anyway, so a patient is having hypotension. What will you do next?
Uh, so we have to start IV fluids along with
Yeah.
inotropic agents.
Okay. No need of inotrope. The patient is having
Okay.
90 60, MAP will be more than 65. So you start fluid. That much is enough. So okay, so I wanted to ask further questions based on this. Patient is having MI. So this patient has pain only for 4 hours, right? What will
Yes.
you do?
So we go ahead with the coronary angiography.
No, straight away this patient. Okay, this patient came to a peripheral hospital where there is no facility for coronary angiography or PCA. Either CAG or PCA is not available there. Neither or not. So what will be the management?
So
Just tell
at
me.
site, yes, sir, we can give as loading doses of aspirin, clopidogrel, and statins,
Yeah,
followed by thrombolysis can be done with
exactly.
tenecteplase till we shift the
Okay.
patient to the tertiary center.
Exactly. So within 10 minutes, the ECG should be taken, and the decision to thrombolysis should be done ASAP. And if thrombolysis is done, then the patient should be shifted within 90 minutes to a PCA capable center because even if a thrombolysis, the lesion is still there. So you have to shift the patient immediately to the PCA capable center where they will do PCA. Okay. So what will you call a successful thrombolysis?
So there will be a AVNRT after thrombolysis, and
No,
the ST elevation will
AVNRT. No,
not
no,
be
no,
visible.
no. Don't confuse. Don't confuse. Okay, yeah. So
AVRT, sorry.
basically, no, it's AIDR, accelerated idioventricular rhythm.
Oh, sorry, yes, yes.
Okay, so patient will have because of the repopulation, there will be increased vagal activity. The vagal predominance will cause the SA node and the AV node to go to a standstill so that the ventricles will take over. So the patient will have accelerated idioventricular rhythm. But
Yes.
successful thrombolysis is not that. Successful thrombolysis is prompt resolution of chest pain along with the ST segment elevation should also be decreased. The height of the ST segments should also be decreased by more than 70%. Usually during PG they use it as 50%, but textbooks say you have to do it. The ST segment elevations should be decreased by 50%. You can either take the average of the pre-chord that is V1 to V6, you can calculate and divide it by 6, and you can do like that, or you can see the ECG wave which is having maximal ST segment elevation, and we can compare the two. Is and the time gap between first is pre-thrombolysis and the post-thrombolysis should be 60 minutes, 60 to 90 minutes. I think that much is enough for this ECG. We will go to the next case and next person be ready.
For the next case, Dr. Bhavna, are you there? Dr. Bhavna? Dr. Hareen, are you there?
Yes,
So, Dr. Hareen, this case is for you.
a 46-year-old male presents with progressive protrusion of both eyes for 6 months, associated with redness, tearing, and a gritty sensation. Symptoms are accompanied by intermittent diplopia and mild pain on eye movement. No history of trauma or significant visual loss. Examination shows bilateral proptosis, lid retraction, and restricted extraocular movements, more pronounced on upward gaze.
Yeah. Yeah. Can you tell me the differentials or tell me the diagnosis? I think everybody
Uh,
knows.
my differentials would be uh, uh, chronic, chronic. So there can be space occupying lesions, tumors, or it can be Graves' disease,
Yeah.
because of proptosis.
Yeah.
And,
Yeah. So it is most likely to be Graves' disease.
okay.
Actually, the most important thing which is missed here in this case is the pulse rate of the patient. So the importance of this case is whenever you are sitting in OPD and you happen to see this patient, the first thing you have to check is you have to check the pulse rate of the patient. And if you're suspecting Graves' disease, the next most important thing is you have to start these patients on beta blockers straight away, because these patients are always at higher risk for malignant arrhythmias. They will die of arrhythmias. So these patients should be compelled to rest, to take rest, and we should start these patients on non-selective beta blockers like propranolol or nadolol. The dose of 40 mg BD, higher doses of beta blockers you have to start with, unless the patient is not having any asthmatic attack or peripheral vascular disease. So, and another important thing is you have to, if patient, for this patient, obviously we'll be doing a thyroid report, right? And thyroid report you are sending and it comes as thyrotoxicosis with TSH of less than 0.001 because of the primary hyperthyroidism.
Yes.
The next thing you have to do is you have to start this patient on antithyroid drugs. What is the drug you will start?
Uh, Anti-thyroid drugs, there are carbimazole, methimazole, and
Yeah,
propylthiouracil.
exactly. Yeah.
In this
So,
patient,
yeah,
carbimazole or
yeah, exactly.
methimazole.
Yeah, this comes under the brand name of Neomercosol. So the important trick here is the practical point is usually we will many prescriptions I have seen these they will start at the low doses of 10 mg BD or 5 mg TDS. So these are utterly nonsense because utter nonsense because what I'm telling is we have to hit hard. So if you have to hit very hard on the thyroid so that the thyroid production comes to a standstill. So you have to start these patients on very high dose of carbimazole 20 mg TDS. I have seen people who are given 30 mg TDS and all. So carbimazole always should be given at a higher dose. Then once the thyroid is stabilized, I mean the TSH levels are coming normalized, then we can slowly taper the dose to maintenance levels of 10 mg TDS. But you have to hit hard and you have to hit fast. So always start whenever you sit in the OPD, always start this patient first on beta blocker. Then you start Miyamicosal and restrict bed rest for these patients. Okay, if this patient presents with tachyarrhythmia along with hypotension, then it comes into a different sort of disorder. That is, it becomes a thyroid storm. If thyroid storm is
Yes.
present, the management is totally different. Where you have to give potassium iodide, then high doses of steroids, and you have to again give antithyroid drugs. So that management is entirely different, which you are not going to see that much commonly nowadays. But the most common thing is acute thyrotoxicosis. You have to always strict bed rest and you have to give necessary beta blocker medications and antithyroid drugs. That is enough. After that, so okay. Now a patient is having, you are thinking of Graves' disease. What is that investigation you will do to look?
Uh, Thyroid function test.
Yeah. Yeah, T-cell receptor antibody obviously will do, right? So
Yes.
this is a disorder of product autoimmune disease, which is because of the production of T-cell receptor antibodies, which will go and set in the receptor and it will stimulate primary hyperthyroidism. So you have to do the test. And one more important thing you have to do is you have to always do radioactive iodine study. Okay, in the radioactive iodine study, what will be the pattern of uptake?
Um,
It
it,
will be diffuse. It will be diffuse uptake. If it is MNG, there will be patchy areas of uptake. If it is single nodal greater, the only the nodule will take. If it is malignancy, obviously it will be cold nodule. Obviously, malignancy won't present like this. So this is a functioning hyperthyroidism. There will be diffuse radioactive uptake for these kind of patients. And you can start with drug therapy. And if drug therapy is not controlling the thyroid storm, then we can proceed obviously with surgery, total thyroidectomy along with replacement of thyroid hormone. I think this is enough for this particular case. Yeah, we will go proceed with the next case.
okay.
Coming to case number 3. So, Dr. Ari, are you there?
Hello.
This case is for you.
Yes, sir. Uh,
Yeah.
uh, A 55-year-old male presents with bilateral pitting edema of the lower limb for last 3 months, gradually progressive and associated with breathlessness on exertion and fatigue, fever, or localized redness.
Yeah. So this is a simple case of pedal edema. What are all the
Yes,
causes
sir.
of pedal edema?
So pedal edema may be unilateral, may be bilateral.
Okay.
It may be pitting or non-pitting. If it is unilateral and non-pitting edema, it may be cause of lymphatic obstruction. And
Okay.
if it is bilateral and it is a systemic cause, then it is a pitting bilateral edema that maybe reflect the polyinvolucrate state or maybe due to hypothyroidism. Or if there is temperature, tenderness, and swelling, and then maybe it due to soft tissue infection like any SSTI or any injury by pricking, needle injury, or bite injury.
Okay. So pedal edema we will divide into two initially, pitting and non-pitting. In pitting, what textbook says is pitting with rapid recovery and pitting with slow recovery. So if the pitting recovers within less than 40 seconds, that is rapid pitting edema, which happens in conditions of low serum protein, that is low oncotic pressure, like nephrotic syndrome, etc. And if pitting requires very slowly, it takes more than 40 seconds due to increased hydrostatic pressure, then heart failure and your case of DVT, everything comes into the picture. So since this patient was having pitting pedal edema, that is C, most of our graduates are confusing pedal edema with left side heart failure. Pedal edema is a sign of failure of the right side of the heart. Okay, we have seen so many COPD patients who are having pedal edema. Why? Because the COPD is obviously leads to right heart failure. Right heart failure then cause pedal edema. So patients only having left heart failure, they definitely won't develop pedal edema unless or until they have right heart failure also. So this patient is
Okay.
already having pedal edema along with breathlessness and exhaustion, which is suggestive of left side of the problem. So this patient is more likely to have a biventricular failure, most possibly cardiomyopathy. If he is having risk factors for diabetes and hypertension, then possibly ischemic cardiomyopathy. Or if he is an young patient, the dilated cardiomyopathy forms the case. So with history only, we can tell which chamber of the heart is involved and what is the pathogenesis. So there was no issue of chest pain, fever, or localized redness. We said there is no cellulitis, obviously. So this patient most likely, this presentation explains patient is having cardiomyopathy, possibly biventricular dysfunction. So that much is enough. So cause of low oncotic pressure, that is low serum protein, include obviously nephrotic syndrome, malabsorption syndromes, and obviously chronic liver disease. And coming to pitting period edema with slow recovery due to increased hydrostatic pressure, obviously congestive cardiac failure, pericarditis, and local causes like DVT and inferior vena cava syndrome would also come. So this much is enough for period edema part. And
Yes.
obviously pedal edema, non-pitting pedal edema, as you are told, hypothyroidism and pretty bad mixed edema in hyperthyroidism like Graves' disease. And the lymphatic obstruction can also be the cause. And congenital lymphatic obstruction like Milroy disease, etc. also become part of the problem. So this much is enough. And one more thing, actually my consultant has proved me many times. How will you check pedal edema?
I will check pedal edema just proximal to the medial malleolus.
Yeah. Just above the
To
medial
visit.
malleolus. And
Mm.
most of us, what I did is I just went and just pressed and took my finger off. You should not do like that. You have to press the fingers for nearly 1 minute.
Yes, sir.
Then only you have to take it. So whenever they tell you above the medial malleolus, press it for at least 1 minute and then take it out. Just go, don't go and press and come back. Otherwise, it will be an embarrassment as it did for me. Okay, so going to the next case.
Yes, sir.
Still blanching of nail, I don't know. Maybe.
Next case is for Dr. Bhavna.
Hello.
Yeah.
A 65-year-old male, chronic smoker, 45 years, presents with progressive dyspnea on exertion, chronic productive cough, and occasional wheezing for 5 years with worsening symptoms over the last 2 weeks. No history of hemoptysis or weight loss, exacerbation triggered by a recent upper respiratory tract infection.
Okay. So this patient was a chronic smoker and he was having respiratory illness for the past 5 years, right?
Yeah.
Yeah. Can you read the X-ray?
So this X-ray is a chest X-ray PA view with
Yeah. Okay. How are you telling this PAV?
so by looking at the clavicles and also if it was a an AP chest X-ray, then that would have shown an apparent cardiomegaly.
Okay. So don't confuse too much. The only thing is you have to look at the scapula. If the
Scapula and
scapula, yeah, scapula is far away from the chest wall here, so it is a TA film. If the
right.
scapula are indrawn and more towards the vertebra, then it is an EPV. That is the trick I used during my PG examination, and obviously the things you have told, and the PA posterior ribs are very much prominent, and the vertebral notches are visible, and as you told, the apparent cardiomegaly is not there. Okay, so that trick which I used was this only, and you have to comment about penetration and rotation. This is an adequately penetrated film, and rotation you have to confirm with the between the two ends of the clavicle.
Mid
Yeah,
clavicular,
mid
yeah,
clavicle. Yeah, yeah, correct. So this
medial
much is
ends of the
enough.
clavicles.
Yeah, exactly. So this much you have to tell, and then only you have to proceed. So can you tell something? What is abnormality here? Yeah, I'm not.
Uh,
Is this overexposed? So the patient, we will come to that. I will tell why it is overexposed or normal exposed.
so
Come to
the
the
anterior, we can see more than 6 anterior ends of the ribs. So,
that is so. Yeah, yeah, yeah,
that
correct.
is that shows this is either hyperinflation is there or this is an expiratory film. And
Mm,
so exposure looks fine because the borders of the thoracic vertebrae are just visible.
okay.
And apart from that, there are prominent bronchovascular markings in bilateral lower zones of the lungs,
Okay.
and the heart shape looks tubular. There is flattening of the diaphragm as well.
Exactly. Yeah.
So that is pointing towards chronic bronchitis and emphysema basically.
Yeah. So this is emphysema. There is bilateral flattening of diaphragm there, and there is hyperinflated chest. That is the clue. And chronic smoker for the past 5 years. So this is obviously emphysema. I think everybody knows the diagnosis before I'm telling. And it's acute exacerbation of chronic obstructive pulmonary disease. So what is the criteria for the COPD?
For COPD, we use gold staging criteria
Yeah, yeah, you can click.
based
Gold
on
staging. Yeah, okay.
FEV1 upon FVC ratio,
Okay.
and we also categorize it. Nowadays, we categorize it into 3 categories: Group A, B, and C. Group A, B, and E
Group
rather.
E. Yeah. So what is the drug of choice for COPD?
For COPD, the drugs of choice are bronchodilators. We prefer long-acting muscarinic agonists and inhalational corticosteroids.
No, no,
Of
no,
course,
no, 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 no.
before that, we
Yeah,
advise smoking cessation
nothing. See, steroids are only for asthma. Okay,
for
so
reducing
don't confuse.
inflammation. Yeah,
Yeah, but here
steroids.
there is no, 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 no. La,
Yeah,
steroids are only for asthma. Here we have to prescribe steroid only if the observed eosinophilic count is more than or equal to 300 per millimeter
300.
cube. So here there is no role for steroids. Here the disease is due to smoking and there
La,
is degeneration. Only you can
mm,
proceed with LABA or LAMA
Lama or
initially.
Lama. Yeah.
Or
Mm.
after that, if it is still not controlled, you directly give LABA plus LAMA. The drug available in the market is tiotropium
Mm.
with
Uh,
formoterol.
that
Not
also has
salbutamol.
steroid. Uh,
No, no, steroid they won't add. Okay, so it is a diuretic they will use. Steroids,
Uh,
that is the common mistake we are doing. Here in practice, usually we give steroids. Most of the outside practitioners are giving that, but steroids should not be used in this condition. And these patients are very much prone for respiratory tract infections. Steroids are not the essential drugs to be given, and the pathophysiological basis is also not there to give steroids. And steroids should be given only if observed eosinophilic count is more than or equal to 3. So, yeah, we can go to the next question.
Next question is for Dr. Sonam, and it's also the final case for today. Dr. Sonam, are you there?
Yes. A 45-year-old male farmer by occupation presented with complaints of intermittent high-grade fever with evening rise for 2 months, dry cough for 1.5 months, and significant weight loss over the last 3 months. So this is a PA view X-ray, normal rotation, and rightly exposed, suggestive of miliary deposits in bilateral lungs, most likely tuberculosis based on the history and symptoms.
Okay, everybody knows that immediately. I will ask one more question to you. If this patient present with complaints of breathlessness alone and palpitation, okay, on examination, you find a loud S1, what will you diagnose?
MS,
Yeah, MS, acquired
rheuma-
hemochromatosis. Yeah, rheumatic heart disease with MS, and this miliary pattern can also happen in pulmonary hemochromatosis.
yes, okay.
Yeah, so actually we had a patient. He was a case of mitral cirrhosis for the past 25 years, and he was admitted with pulmonary atrial fibrillation with pulmonary edema nearly around 20 times. And even consultants are told we will operate him. We will admit in this admission only in under CTVS. The patient was not willing. He was scared of surgery. And every 2 weekly, we will admit with the atrial fibrillation with rapid ventricular rate with MS, and we will discharge him with the rate. So nothing much. Will directly okay. We will deal with the recent changes in that NTEP, National Tuberculosis Elimination Program, which is the changed version. So, what are all the investigations they will do in this patient?
So normal laboratory investigations including CBC, renal
Mm,
function test, liver function test to rule out
mm,
disseminated tuberculosis.
okay.
Then we can, if the patient is producing sputum, we will go ahead with the gene
Mm,
expert, TB-PCR, cultures, gram stains,
mm,
and
mm,
MTB culture.
mm,
And we will, if it comes out to be positive, then we will go ahead with first line probe assays
mm,
and see if there is rifampicin sensitivity or resistance or not with gene expert
Okay.
TB-PCR.
So, yeah, basically, previously they didn't do line probe assay. Okay. Line
Hmm.
probe assay was not necessary, but now both CB net and culture followed by LPA from that culture is mandatory now. So every patient who are being detected with the TB, we have to proceed with line probe assay. That is very, very, very important thing you have to remember. And second, is miliary TB a pulmonary TB or respiratory TB?
Mhm. So disseminated
Obviously. So what is the duration?
for treatment, sir.
Duration, yeah, treatment.
Uh, six normal, so 2 plus 4
Here you have to give two
extended.
months of intensive phase, but around 10 months, 6 to 9 months, you have to give extended periods of continuation phase for these kind of patients. So you have to
Okay.
give nearly 1 year of UPT. Okay. So another important question regarding TB is what is the natural history of TB?
Um, so
Yeah.
in the sense,
Natural TB starts from where and TB ends where? In which organ?
It starts from the lungs
Okay.
and can end in ad- bones or adrenals. Not sure.
Yeah. So actually, TB starts in pleura.
Uh,
Okay. So we might have seen many patients who are being referred from peripheral GHS or case of pleural effusion, and they would have done CT and they would have not tapped the patient, but they will straight away start ADT for this kind of patients. So TB starts from pleura, then the pulmonary, then the other organs. So you have to remember that. So TB always starts with pleural effusion, very very important. This also comes handy when presenting cases actually. One important thing, interesting thing happened. I will tell later. So the recent advances also you have to be very very attentive to. And what is default regimen?
So, bedaquiline, delamanid, linezolid, and pyrazinamide is given over 6 to 9 months.
Yeah, it's not bedaquiline, pretomanid.
Oh,
Okay,
sorry,
pretomanid.
P.
So the drugs for drug resistant TB are coming. Big names are coming. So we have to be very very updated regarding that. And coming to the last question, one more thing I have to ask was what is fibrothorax and what is fibrosis?
So, fibrothorax is after a long-standing pleural effusion,
Yeah,
the pleura fibrosis, that is fibrothorax, and
exactly.
fibrosis is lung parenchyma.
Yeah, yeah, you're clear. Okay. Yeah, this much is enough for you. So the difference is very, very important, and you have to read how to examine this kind of patients. So in my MD exam, I got fibrothorax only as the case. Okay, so patient had history of prior pleural effusion, and the trachea was shifted to the right side, and patient was having findings register of pleural effusion. So always, whenever patient is having findings register of pleural effusion, that is absent red sounds, stony dullness, and percussion, there is nothing absent red sounds, but the trachea is shifted to the same side. So patients will have all features of pleural effusion, but trachea will be not shifted to the. You will expect obviously in pleural effusion the trachea to be shifted to the left, but these patients will have trachea shifted to the same side of the pleural effusion. So whenever you are having that, first thing you have to think is fibrothorax. If patient was having prior history of pleural effusion and the placement of ICD, which that my patient had, and second you have to think of mass, that is a mass lesion with the
Mass,
pleural effusion.
CA.
So that can cause compression of the bronchus and same side shifting of the trachea. So we have to be very, very careful with that. And don't miss fibrothorax in your differential diagnosis. Whenever, whatever you see a patient with pleural effusion, finding registered pleural effusion with reduced breath sounds and reduced movement and nothing to give a clue, but trachea shifted to the same side, don't tell pleural effusion and tell fibrothorax. Okay, because why it asked about the natural history of TB is TB always starts from pleural effusion. So this patient even might not have any intraparenchymal lesions. Only fibrothorax might be there because of the prior history of placing ICD insertion and all. So we have to be very, very careful in exam regarding that. So fibrothorax is a very, very important differential to consider in this patient. That's all. Yeah, thank you.
Thanks, sir, for this wonderful session and giving your valuable time to us. So, those
Thank you.
again, for concluding the session, I will introduce Dr. Sandeep again. Dr. Sandeep, you can find as resident007 in Instagram. Instagram handle link is also given in the description. Thank you, sir.
Thank you.